Okay, good morning, everybody. It's a pleasure to have Mauricio Medina here visiting us for the functional position. Mauricio just finished his fellowship at Cleveland Clinic. He is actually triple fellowship trained. He's a very slow learner, obviously. First he trained in Mexico City, went to a hospital that I know very well, ABC, and went to the best place at the National Institute of Neurology and Neurosurgery. Finished his residency in 2017, did his PhD at Northwestern in neuroscience, then did Cornell fellowship in pediatrics, did Yale fellowship in epilepsy, and just finished a functional fellowship in Cleveland and the Cleveland Clinic. And now we're delighted to have you visit today. You're going to meet some of our faculty, but we're looking forward to hearing what you have to tell us on single neural recordings. And I'm sure there are many people on Zoom. I don't know who they are right now, but listen.
Okay, thank you so much. Good morning, everyone. Thanks for being here with us and with me. Thank you so much, Dr. Morcus, Dr. Tandon, for inviting me. It's really a pleasure to be here. I'm humble and excited. And first and foremost, I hope your families and you guys are doing well. And that you're recovering from the scary time that Corona just brought. I'm sorry to hear that some of you still have no power or water working properly. So I'm sorry about that. So I'm going to present to you some of the work I did with Dr. Spencer and Dr. Lammitz at Yale, as well as some cases I did at Cornell and Cleveland. My talk will be primarily focused on single unit recordings that we were studying cognitive processes in patients that underwent SEEG. So we studied patients in the EMU, they had SEEG, we put some microelectrodes and we record single neurons and see what we can understand and learn from there. Please feel free to interrupt me with comments, questions. I want to make it a little more interactive or as interactive as possible. So just as an outline of the talk, I'll show you some of the current techniques we have and innovations for invasive monitoring in epilepsy, some of the methods we use for isolating units in the human brain, some of the single neuron dynamics that we have now understand a little bit more about a seizure in the single neuron level, the responses we have in the research I did for single neuron responses to a threat, how the human brain is reacting to threatful situations. And then I will finish just talking about advanced technologies to optimize research and also treatment in epilepsy patients. So just to start off, 1.8 million people suffer from epilepsy. We know that in the USA. Around this, 30% will course with drug-resistant epilepsy. So drug-resistant epilepsy is defined as patients with seizures that persist with 2 or more adequate anti-seizure medications that are well tolerated and appropriately chosen. And we know that patients with drug-resistant epilepsy have higher rates of morbidity, depression, and anxiety. They have a higher risk for SUDEP and also very poor quality of life. Unfortunately, we do not know what is the cause and the pathological basis for drug-resistant epilepsy, as well as the associated psychiatric comorbidities. The last report of the International League Against the Epilepsy said that every patient with drug-resistant epilepsy younger than 70 years should be sent to a comprehensive epilepsy center like this one to get studied for surgical candidacy. And we know that from those patients that arrive up to centers like this, 30 to 50% will be studied invasively or will need invasive monitoring. And candidates for this invasive monitoring are those patients with discordant non-invasive studies, multifocal seizure onset zones on scalp EEG, MRI negative epilepsies, eloquent cortex that is involved, and also patients that failed for lip or resection. So I just wanted to give you a little bit of the numbers. From 1.8 million, right, 30%, 600,000 people will have drug-resistant epilepsy. And from this, 30 to 50%, right, 200,000 people at least will need intracranial EEG. So the amount of people and the amount of data that we can get from these people is big. This is one of the cases I did on the couple last week. No, sorry, not last week, but a couple of weeks ago with Dr. Bingham at the clinic. This is a 10-year-old that we implanted with 18 electrodes on the right hand. This kid stayed for 7 days in the EMU. So we recorded 7 days, 24 hours a day And the amount of data that we used for this kit to pinpoint the seizures was less than, I would say, 3%, right? Every seizure is less than 5 minutes. He had 10 seizures that we used for the patient management conference, and the rest of the data is just stored and not used, right? So if we think that on average, there's 7 to 10 days of people getting reported, where's that data going the rest of the day, right? So I've been a very passionate advocate to utilize this unique scenario, to use this data to further understand and investigate some of the neurobiological basis for, one, the pathophysiology of seizures, but also cognitive processes in the human brain. Now we can take advantage of this. So in order to make it a little more interactive and probably more interesting for you, I want to show you a relevant case that was for me. In the time that I was interviewing at Yale, they were starting with a single unit program. And the junior faculty there just came from Germany, actually, with the new technique. And this was the first case that they tried. They invited me for the interview. And I was in the OR just watching all the troubleshooting that they were going through to get single unit recordings. By the way, I talked with several epilepsy surgeons that told me that those electrodes will never get you single unit recordings. So I was very excited to see what the result was. And apart from being a very good clinical case in terms of decision making and results, it turned out to be a really good case for research purposes as well. So this is a 23-year-old male. He's a piano player. He has a master's degree. He works for a company. He's a very high functioning individual. And he is ambidextrous. The onset of the epilepsy started at age 22. There's no risk factors or any other past medical history that was relevant. On his exam, he was non-focal, and he failed several anti-seizure medications. So the burden of the seizures into his life was big, and he needed to do something about it. So he came to us at Yale with 2 types of seizures: focal aware to bilateral tonic seizures. He had an aura of around 15 seconds of dizziness that followed to staring for a few seconds, followed by a right gaze deviation, a head deviation, with the right arm being on a tonic posture as well as clonic movements. This evolved into bilateral tonic-clonic seizures, and post-ictally was confused for 10 to 20 minutes. He had a frequency of 1 every 3 to 4 weeks of these types of seizures. Another type of seizure, and that was the most common, type 1. Type 2 was another seizure that he had, is the focal aware. He just had those auras of dizziness, but he did not go into bilateral tonic. So he came to us with this MRI, showing extensive signal change on the left orbitofrontal region, as well as the inferior frontal gyrus, that was involving the pars orbitalis, pars triangularis. So if you observe this signal change, it was coming, can you see my pointer there? It's coming from the ventricle down to the cortex, that is consistent with a malformation of cortical development, of focal cortical dysplasia, right? This also involved, and you can see it here in the flare, it's also involved the orbitofrontal region, but also posteriorly the anterior and middle insula. You can see the signal change there with hyperintensity on the flare. So this patient was ambidextrous. We needed to know where language was because it was a left lesion, right? So on fMRI, he showed bilateral language, so not super useful. Conclusion of the PET was hypometabolism on the left frontal, left temporal, and left insular regions. On the EEG, we found interictal left temporal sharp waves. This EEG is the first half is on the left side, and the second half is on the right side. I don't know what happened. There. We captured some of the seizures that he was having, staring, right head version, right eye version, with then the arm coming tonic and then clonic. The first EEG signs that we found was a bifrontal maximum slowing, followed by this 3 Hz spike in wave complexes that you can see there, evolving into a very low voltage with high fast activity within these regions before going to the rest of the temporal region, or the left temporal region, or going to the right side. In neuropsychology, he had frontal dysfunction, and because he was ambidextrous, the fMRI was bilateral, we needed to do WADA, and we confirmed that the language was on the right. So he has a left lesion with right language, which is good for him, but also good for us. So the summary for the patient management conference, this is a 23-year-old, very functional kid left hemispheric focal epilepsy with the hypothesis of left inferior frontal onset with possible temporal and insular involvement, given that staring and behavioral arrest that he had and the focal cortical dysplasia that we saw on that MRI, on the anterior insula as well. So I want to pause a little bit here and invite you to start thinking, what is the resolution we have with these studies, non-invasive studies, in order to render this patient seizure-free without resection? So I plotted for you here the spatial temporal resolution of the studies we have. On the y-axis, you have the size of the resolution. On the x-axis, you have the time of the resolution. And as you can see, the EEG can give us up to the lobe, MRI can give us down to the gyrus, but really the time of that resolution is really bad. So in order to get this patient with the optimal result, right, the resolution with these studies will not be enough. In this case, probably we'll need to resect 3 complete lobes, right, frontal, temporal, insular. So we cannot do that. So we, unfortunately for this patient, we have invasive monitoring, right? So we can record with little electrodes inside the brain in order to pinpoint inside the lobe where in which gyrus, for example, are the seizures coming from, right? Even though we know that the neurons are the basic units of seizures, but also of brain function, we're not studying neurons during epilepsy. And as we know that epilepsy surgery involves a cost function, right? There's a trade-off between removing pathological versus functional tissue. So as we increase the resolution, you can see how we decrease the negative effect to the functional brain. So unfortunately, we do not have a lot of data, and it remains nearly absent in clinical neuroscience reporting single neurons. And what is this? What's the reason because of why we don't have this? Probably because of the technology, but probably because we do not understand really the neuronal origins of the seizure. So can we, if we get better resolution of this, can we get the patient, better optimize the patient with this cost function? So for the last year, every day, I went to the OR. For example, in this case, we recorded single neurons in patients with movement disorders, right? This is a patient with Parkinson's disease. We did STM recordings, and we get the neurons to fire and to know that we are there, right? So in this case, we use single neurons since the 50s to get the sweet spot or where the patient is going to respond to. So every time I go to the OR and I listen to this, I think, why are we not doing this in epilepsy? And in movement disorders, neurophysiology dictates the sweet spot, but we are still not using this in epilepsy, and probably due to the better understanding we have of the movement disorders circuitry, but also because epilepsy might be a network disease. So based on that, what do we know about the neuronal origins of a seizure? So the dogma of the origin of a seizure starts since Jackson in 1870, right? Victor Horsley and Jackson describe a seizure as an excessive and disorderly discharge of nerve tissue. And from there, we have not changed a lot our premise, right? The current premise is that a seizure is due to an abnormal, excessive, and synchronous activity in the brain. And there have been very few studies investigating or going beyond the microscopic scale into intracranial EEG signals to examine what the neuronal spiking is underlying seizure. For example, this study took from lobectomies in patients with epilepsy. They reported on the lower trace, you can see that is the interictal spikes, and they recorded intracellularly into an interneuron, and they saw that the spikes of the interictal spikes were correlated one by one to that spiking or the actual potentials of that interneuron. They did the same with pyramidal cells, but there's actually not a lot of data on this. So the dogmatic feature is there's increased excitability in the neurons during seizure. And a common feature as well is that there's abnormal and enhanced synchrony of those neurons. But we still don't know what the spike train pattern of a human neuron is during a seizure. And this is one question that Sidney Cash at Boston, his group, had. So what they did was using 96 microelectrode arrays in 4 patients with focal epilepsy. They put this little Utah array, I don't know if you know it, it's around 100 microelectrodes in a very tiny array. They put that in the middle temporal gyrus, as well as putting ECOG strips to record seizures from 4 patients. The yellow squares are the subdural electrodes in the temporal and the occipital lobe. And as you can see here, this is 0 is the time of the seizure onset. And as you can see on the 2 first ones, there's high activity on those ECOG that are being reported, the seizure. This is also the local field potentials of that microelectrode array. And you can see the spectrogram with high beta and high gamma powers here. But what's really interesting in this study is that they recorded 150 neurons. So if you see here, there's a raster of the 150 neurons. On the y-axis, the neuron number, and every dot here is an action potential of a neuron. So this is aligned, this time 0 is the seizure onset. And as you can see, there's no homogeneous activity of those neurons, right? There's some neurons firing, but most of the neurons are actually quiet after the seizure. So this breaks the dogma that we have. Well, seizure is increased excitability, a lot of action potentials, right? There's heterogeneous and not synchronous, and there's inhibition more than excitation. And as you can see here, there's 2 examples. The neurons, those are action potentials. After the 0, it's completely quiet, and then it gets firing again. This is another unit that they record. And then after the seizure termination, but they see this homogeneous, almost complete cessation of the spiking. So this gives us an idea, and this suggests that we need to revise our current thinking about seizure mechanisms, right? So what has been the challenge to record single neurons? Well, we're trying to record human action potentials, right? Neurons are 7 to 10 micrometers diameter in the human brain, and we're trying to record from those little guys. So there's been challenges, technological challenges to get this to work. And the way we do it, there's 2 ways, intraoperatively or extraoperatively. Intraoperatively, or the acute recordings, there's some people using microwires, as we do for DBS, for recording STN, for recording the thalamus as well, or the GPI, microgrids as well. And there's also some groups using silicone probes like this one. They're non-FDA approved, but they can record with 1,000 electrodes, the cortical layers of the temporal lobe, for example, that is going to be resected in patients with epilepsy. The other type of ways or techniques that we use, they are the extraoperative techniques. These are the UTHealth that I just showed you. This is an example. As you can see how little it is less than the base of that painting, of the Lincoln face. We also have hybrid SEEG electrodes. And in the 2000s, Binky and Dr. Fried in UCLA developed this hybrid electrode. It's made by Atec. It's a normal electrode we use for SEEG, but it has those microwires that are protruding from inside the electrode. Those are hollow, and they just put those 40 microns diameter microwires that they are high resistance and that you can actually record single units. There are other groups doing some wireless recordings as well, or Elon Musk also, right? Using Neuralink with this new electrode that they are recording as well, single units. It's important to say that UTHealth has been big in the 90s for brain-computer interfaces for patients with spinal cord injury to move robotic arms or to move and stimulate the muscles. So is it safe then to use these microelectrodes in SEEG? Dr. Fried in UCLA just reported case series for more than 200 implanted patients with these electrodes. They found 79% of these patients underwent resection, 65% had seizure freedom, just as reported in the normal literature. And they had more than 18,000 microwires implanted in the patients, right? 52 neurons around per patient, and they have multiple scientific discoveries for this. I don't know if you've heard of the Jennifer Aniston cell. This is the group that reported it. These are neurons in the temporal lobe that were only firing to when Jennifer Aniston figure was set in the screen, but not to any other person. So these are the grandmother or constant cells that were big in the 2000s. And they have only 2 complications, one ICH, one infection, which is the rate of 1% that is reported in the literature for 1%. So it seems like they are safe, and they can bring also clinical decisions as the normal electrodes, but also scientific discoveries. So coming back into our case, right? This kid, 23-year-old, left-sided focal cortical dysplasia, right-sided language. So the committee recommended intracranial EEG for the epileptogenic zone localization. So we implanted the kid with left frontal lobe that was extensively covered with electrodes spanning through the inferior frontal region, including the site of the focal cortical dysplasia, the pars orbitalis, the pars triangularis, electrodes in the insula, but also in the limbic network, including the cingulate, the hippocampus, and the amygdala. We recorded seizures in the EMU. That's the patient is plugged, and what we do here is we split the signal into the research signal, but also the clinical signal. So no clinical signal is lost when we're doing any type of research. And we capture several seizures. This is one example of a seizure. The EEG onset starts with half a second of diffuse attenuation that is here. And after that, you can see a rhythmic 7 Hertz spiking that is maximal in the frontal orbital as well as frontal orbitalis, frontal polar regions, right? 1.5 seconds after this, the patient is not having any clinical seizures, but it spreads to the insula, to the anterior insula. This is the lumen insula electrode on the most anterior part of the insula, and it's spiking again on these electrodes. This kid had the same semiology. These are the habitual seizures. The patients described to be drowsy, and the first clinical sign was eye-opening that started with 8 to 10 seconds after the intracranial EEG onset, and then he started with the right hip version that you're going to see in a second, and then the right tonic posture of the right arm and tonic movements, right? Just as a summary, again, we see the seizure onset, 0.5 seconds of that diffuse attenuation of all the intracranial rhythms before the onset of that 7 Hertz rhythm that was spiking on the frontal orbital, orbitalis, and the lumen insula as well. And then an ictal rhythm that develops as a rhythmic beta, right? And spreads throughout the adjacent frontal lobe. And only 19 seconds after the EEG onset, the temporal neocortex is also evolving into that rhythm. So the conclusion of the study, we have habitual seizures arising maximally from the orbitofrontal, the focal cortical dysplasia, and the orbitalis, pars orbitalis. We have also early or simultaneous involvement of the basal frontal as well as the lumen insula in those electrodes. And those correspond to the regions of the focal cortical dysplasia. And the mid and posterior insula depths are spared equally until generalization. So we don't need to resect those. Patient had right language that we also stimulated those electrodes, and that also corresponded with the blood. So we implanted this patient with those micro wires as well. So he had not all of the electrodes were having micro wires, and this is actually one of the reconstructions of one of the patients. As you can see, those 8 micro wires are protruding. They are 40 microns on diameter. And they are 6 to 8 microwires. So first I was really curious to see, can I see those microwires on a CT scan, right? That was the first question, where are they, right? So I took a CT scan, the post-op CT, just fused it with the MRI. And as you can see there, there's those little hairs, right? That are coming into the gray matter of the anterior insula. So I was really excited to see that, okay, we hit the insula, we hit the gray matter. What are we gonna see? Another patient on the anterior cingulate. I also just fused the CT with the MRI. And as you can see there, those little hairs, those little microwires are protruding from that electrode and they're touching the gray matter. And this was all clinical, the position of those electrodes were based on clinical decision. Right? So now that we have those microwires there, now what? Okay. So at Yale, they bought a big black box system that records 30 kilosamples per second. And I connected that to the big black box. And what I saw was this, which made no sense at all. So I needed to filter this from 300 to 3000 Hertz. And what I found was spikes. Finally, we got spikes. We were very excited. We were able to isolate those single neurons. But now I want you to remember that we are recording with a 40 micron electrode, and we're trying to record 7 to 10 micron neurons, right? So we are in the middle of a lot of neurons, and we need to know if we're recording from one neuron, from 10 neurons for 100 neurons. So the way we do that is using some algorithms in order to cluster those neurons in order to call them single neurons. And as you remember in med school, the actual potential was, going upwards with a sodium current, and then the hyperpolarization, the potassium current going downwards, right? We are recording extracellularly, so everything is flipped. As the sodium is coming inside the cell, there's a negativity, and you will see that with your microelectrode. And it depends where you are around the cell. If you are around the neuron, then your amplitude will be way higher than if you are where the dendrites are or when the axon initial segment starts. So the waveform is different, and then we learned that as we went through. So now we use this software to isolate the units, and this is the raw signal. And with the raw signal, we can use template matching. This is actually free software that you can download, and you just input your raw signal, and it gives you different units that are being recorded in that. So as you can see, the waveform, it detects the waveform that is similar over spikes, and it tells you this is cluster 1, cluster 2, neuron 1, neuron 2. So this is an example of a beautiful neuron that we got. And we also plot the interspike intervals, meaning that how often is the neuron spiking. And as you can see, there's a Poisson distribution very nicely. That's a distribution that is common on very healthy neurons. And if you plot the cross correlation of this, meaning that there's no spikes happening on less than 25 milliseconds, right? If there were spikes happening on less than 2 milliseconds, then you know it's not a single neuron. But this also defines or indicates that this was a single neuron. So then we have neurons. Can we then study some cognitive processes on the single neuron level in the EMU? So as I told you already, that patients with epilepsy have psychiatric comorbidities, and more than 40% of these patients are diagnosed with anxiety. We know that in anxiety disorders, a person experiences fear that is out of proportion to the event, and then there is impairment of a normal function. There is anticipation of a threatful event that most of the times is uncertain. So people with anxiety will show abnormal and excessive avoidance behaviors, right? Very anxious people will not drive because they think they will crash, right? Even though it's uncertain that they will crash, they think that they will crash and there's a threat, so they don't do it. The current literature points towards a disbalance in regions and circuits that are involved into threat-related processing. And these regions are the amygdala, the insula, the anterior cingulate as well, in the periaqueductal brain. And there has been studies of neurocorrelates of how people perceive threat. And this has been done with fMRI. There are 3 specific regions that have been implicated in salient or threat event detection and threat reactivity. And these are called the salience network. They were detected with fMRI. These are the dorsal anterior cingulate, the anterior insula, and the amygdala. And the activity of these regions correlated directly, linearly, with anxiety. So if you have a very active salience network, you might have anxiety, or your rating scores for anxiety will be higher, right? So based on this, can we then parse out the spiking code that is underlying this threat reactivity and avoidance in the human brain? Now that we have some electrodes in the insula, some electrodes in the anterior cingulate, how do they look like? But how do we study threat in the EMU? That was one of the things. We needed to come with something smart. We cannot threat the patient. So we collaborated with a very smart collaborator researcher in UCL, Toby Weiss, that designed this active avoidance game-based task. This task is basically the patient is playing with a laptop, is trying to navigate this spaceship in order to avoid getting hit by those asteroids that are coming every 6 to 7 seconds. And the patient, every time it crashes an asteroid, there's 2 safety zones, right? As you can see. On the top and the bottom, there's 2 safety zones that the patient needs to navigate that. Every time there's a crash, the shields or the help comes down, and the goal is to not lose, right? There's 270 trials, 270 times that this comes. Of course, the patient will be advised to tell us when they want to stop, but most of the patients were very happy and very engaged to do this. Another important part of this study is that it's able to replicate some of the behavioral patterns with more traditional studies that use painful stimuli or noxious stimuli. And it's been validated to induce anxiety in state anxiety individuals. So this is the workflow we have, right? We have the patient in the EMU. We connect the patient to the clinical side, the natives. We also connect the patient to the BlackRock. As the patient is playing with the laptop in the bed, we record everything that is happening. And then from the bedside, we put it into the bench and we do offline analysis of the task, of the pupil of the patient, but also of the recordings that we're getting from the single neurons. We isolate the single neurons. And one good thing about this task is that you can see the behavior of the patient. This gray trace here is how the patient is moving the spaceship. The blue trace here is how the health is coming down. And as you can see on the first 40 trials, the patient died and then game over again started. And then the health started to be more and more stable as the patient played. There's 2 safety zones there in pink. And most of our patients were able to decrease the percent of our crashes as they completed the task. We also know that this task was able to induce anxiety, but we wanted to know if it was able to induce physiological arousal. So we measured the pupil. And what we found was really striking. Most of the patients will have dilation of the pupil when the asteroids just come into to the screen. So this means that this patient has with a pupilometer. It's just a camera that we put on some glasses, and it's a camera. We did this in healthy individuals. We didn't do it in the patient
But you can do it on the patients too.
You can do it in the
eye
patients.
tracker.
Yeah.
Eye tracker on top of the computer screen.
Yeah, and it's just a camera that's detecting the using to like calibrate it. So we were very excited that this induced physiological arousal with the people. So then what would happen with the electrodes? So first we needed to see where the electrodes were. So we verified this with MNI space imaging, where we co-register our electrodes to MNI space. Those are the ACC, those are the insular electrodes, and we have so far 9 patients. So what will happen there in the anterior cingulate? What we found was when we aligned the neurons to the moment of the asteroids appearing in that screen, we found, I'm plotting for you here on the top, up on the top is the behavior. The middle one is the spikes or the raster plot. Every single dot is an action potential of that neuron that I'm showing to you. And then the lower part is the firing rate calculated based on the law. And the waveform on gray, you can see. So that we saw was that this neuron was very quiet during when the asteroids were not in the screen, but as the asteroids appear in the screen, it increases more than 2 times or almost 3 times their firing rate, and it decreases as the asteroids are disappearing from the screen. So we also categorize this. Well, maybe this neuron will be able to differentiate between crashes or avoiding the asteroids. But this neuron was actually just caring about the asteroids appearance. So we call this the appear responsive neuron. And I want you to make sure that we're not reporting from visual cortex, right? This is not just a visual stimulus. We're on the frontal cortex, on the dorsal anterior cingulate, and this is detecting something that is happening. So it's a salient event, and we have a neuron that is following that event in the screen. This is another type of neuron, another example that we found. It's increasing a little later than the first one, but this neuron really occurs when the patient avoids getting hit. When there's crash, this neuron is not firing. But when the patient is avoid getting hit, or there's a positive outcome, this neuron really fires up. So we call this the avoidance responsive neuron. We have around 100 neurons in 8 subjects, and I'm plotting for you here the responsive neurons, 54 neurons that we have. The color code is the change in firing rate that is normalized. From 0 is the time of appearance, then this is the time where the asteroids come out. And as you can see, most of the change in firing rate of all those neurons happen when the asteroids are in the screen. So across all subjects, we had 33 neurons that were appear responsive, and as you can see, that's the population average that is really nicely increasing their firing rate in these neurons, this detected neurons. This is the baseline, and after the baseline, when it appears, all of the neurons are increasing, both for crash or for avoidance. And as we do the analysis of the statistics across subjects, we find a significant difference for that. So it seems that the ACC neurons might represent this salience of a visual stimulus coming into the screen, and this might help orient the attention to relevant events, right? But now, what is the insula doing? So we found that some of those insula neurons were not really taking care or representing where the asteroids are coming. But this neuron, when we categorized its crash or avoidance, this neuron really increased their firing rate when there was only for crashes, right? So we call this the crash responsiveness. And there was another type of neuron showing differential firing rate for crash or for avoidance, and we call this the event responsive neurons. We have 103 neurons in 7 subjects. You can see that most of the change in firing rate happens when the asteroids are in the screen. And we had 13 are pre-responsive neurons in the insula that did not show a lot of response, but we have 32 neurons that are event responsive on the insula. These are crash units that they increase only for crash, but not for avoidance, and 15 units that increase for avoidance and not for crash. You can see how they divide very nicely. So this means that the insula might be able to differentiate in between the outcomes. We did this for the preferred either crash or avoidance, the preferred event, and we found significant differences across the 8 subjects that we reported. So it seems that the insula might be represented positive and negative values of the events that are happening. So the summary of the research, we have this task that is inducing physiological arousal. We have a population of neurons in the ACC that is detecting the onset of a threatful event. We have a population in the insula that is differentially encoding the outcomes of a threatful task, possibly assigning a subjective value to each of the outcomes. Just for the sake of completeness, what happened with our patient? 23-year-old, left from a focal cortical dysplasia, right language. So we resect the basal frontal lobe, including the left inferior frontal gyrus, orbitalis, triangularis, and opercularis. We also resect the lateral medial orbitofrontal gyri, as well as the anterior and middle insula. And the patient has been seizure-free for 1 year. He has an intact exam, and he also participated in this research. Finally, what are the advanced technologies that we have to optimize our results on research, but also on treatment? So we have diagnostic robotic SEEG, high resolution grids that can give us some of the single neuron activity for neuropathological basis of seizures, but also for cognitive processes. We also can use these electrodes for guiding our resections as well. This is a resection that we did for the insula that was guided through that electrode. We also had endoscopic assisted excisions of, for example, this hamartoma that we did with a patient with gelastic seizures. Laser ablation. We have this new clinical trial, the GABAergic intraneural cell transplantation for epilepsy in the mesotemporal lobe, and as well neuromodulation, RNS, PBS, and BMS. And with that, I hope I was able to convince you that hybrid SEEG is a safe and reliable technique to retrieve single units in patients with epilepsy. That single units during SEEG helps advance our understanding of seizure pathophysiology, but also of approaching scientific questions like the ones I showed you. Cingulate cortex might be detecting the onset of a threat, while the insula might be encoding a subjective value. And I hope I was able to invite you to start thinking that we might need to start thinking of a cultural shift of the level of analysis we are doing and monitoring in epilepsy. And with that, I would just like to acknowledge all the people that have helped me get to this point in Cornell, Yale. I will take any questions.
Great talk, by the way. For your single unit recordings, when you implant, so in this case, these microwires, 8 microwires that come out, let's say you implant, like what is the percentage of each wire that you would actually get a signal from? Or is it in all cases you get a signal?
No, that's a good question. No, we don't. I would say from every patient, we would get around 40 units, 30 to 40 units. And every patient will have 3 to 4 electrodes with microwires. So there's 32 microwires, 30 neurons.
I see.
That's around the average. Maybe you can get 3 or 4 neurons from one single electrode. microwire, but sometimes you're not lucky enough and you don't get anything from those 8 microwires.
What's the cost difference between those electrodes and a normal, like SEEG electrode?
That's a good question that I actually don't have the number, don't have the digits. But this research electrodes are paid by grants, so the patient would not pay them.
I'm going to ask you a provocative question here, a little bit, right? So when I've stuck to doing cognitive research with SEEG electrodes without doing microwires for one reason only. So the cross-sectional diameter of a Benke-Fried electrode is more than double that of a regular SEEG electrode. So when we say, yes, we're putting these electrodes in for clinical purposes, you know, a 0.8 millimeter electrode versus a 1.2 millimeter electrode are, maybe they don't sound very different from each other.
Mm-hmm.
But when you put the bolt in or the electrode in, they're very different.
Yeah.
Right? Do you tell patients that you're going to put in a fatter electrode because you want to collect single units?
Of course, yeah. When we sign consent for research, we say that.
No, but do they actually understand that? Because a lot of people, like the groups in Cedars-Sinai, UCLA, Mass General, have been publishing on this for a while. But I've never heard an explicit, consent process from a patient to say, the hole we're going to make in your brain is going to be twice the diameter.
Yeah.
Because we want to collect research data.
Yeah. So at Yale, we only used AppTech. We didn't use Dixie or any other. I know Dixie is 0.8 and AppTech is 1.2. At Cleveland Clinic, we do say, we could do 0.8, we could do 1.2. But sometimes it's just, we just go with one type. But I think that's a good.
Well, I mean, to me, it's just, I think, every part of the brain is important, and everyone has to have their own sort of compass of what they think is right to do, right? But I've never been able to convince myself that it's okay to just put in a bigger electrode to collect units. So now Dixie has a micro electrode. So
yes, I heard that it's not working.
They actually demo it to us.
Oh, really?
Yeah, so maybe there'll be some time you can visit with them.
Oh, that'll be
I think that's the future. I mean, you've got to bring this technology into the actual clinical realm.
Exactly. Yeah.
But excellent work. So let me ask you this. So you talked about anxiety and this network. Did you also, in the same individuals, monitor anxiety in a different paradigm and look for any co-activation?
No, but I think that's a really good point. We are studying patients with persistent epilepsy that might have, or most of the patients will have anxiety. We did not measure that or correlate it with the activity. There are some groups actually that are collaborating with a neurosurgery that are trying to test that as well for PTSD, for example, and for anxiety per se. They have some paradigms and they have some tests that they are using for that.
Mauricio, great talk. Slightly different question. What's your assessment today of lit versus open surgery for epilepsy, for refractory epilepsy? Where do we stand? Do you see a day where open surgery will be relegated to barbaric times, or what do you think?
Yes. So I think that's a great question for a lot of discussion. We can discuss this for a long time. But I think it has its very specific clinical indications. For mesial temporal sclerosis, lit is working really well. And there's a lot of papers showing that for hippocampal sclerosis, it works really well. Fortunately, we have now clinical trials that are ongoing. So we want to see the long-term data. We still don't have long-term data for lit. And I think resection still has its part in post-cortical dysplasias that are extensive, like malformations as well.
So we talk.
Thank you.
Question: the data you collect, particularly looking forward in terms of behavioral issues. What do you foresee the utility of machine learning in the sense of the data, such vast amount of data you collect, in the way that whether it can actually feed into potential machine learning, and in the sense that the future how behavior adjustment, and it could be good way or evil way to look at. What do you foresee that?
Yeah, well, in terms of single neurons, for example, I think there are groups that are using now artificial intelligence to start creating algorithms to analyze and cluster different units with different electrodes that we are using. So I think it's coming and it's already here. We're just trying to prove it that it's working as the previous methods we have.
Mauricio, how were you or other groups using single units as part of the epilepsy diagnosis?
To my knowledge, there is currently no one using single neurons clinically to understand, let's say, micro seizures. But that is where we want to go towards.
What are you supposed to look for first?
First, I think to understand what single neurons are doing, for example, in different types of seizures. There are some papers showing that if you have gamma oscillations, neurons are not firing, but if you have high frequency oscillations with interictal spikes, there's a lot of neurons firing at the same time. So we need to understand how the ensembles of neurons are getting the action potentials with the specific types of seizures that we recognize with EEG, scalp EEG or interferon. I think that's how we start to move forward.
Isn't there sort of a technical limitation with the Binky Fried in particular, maybe not with Dixie, but if you're trying to hit the hippocampus, which is a fairly narrow structure, and you have to extend these micros beyond the tip, so you're forced to move the macro outside the hippocampus, and so you would lose HFOs on the tip, but maybe pick them up on the micros. How do you deal with that?
Yeah, so one advantage is that you still have LFPs with the micro, right? The thing is, you don't have the full electrode that you have on the rest of the lead, but every single wire has its own LFP. You can just filter it to record local field potentials, which is the same as you record with the normal electrode.
Yeah.
So you could record high HFOs with a micro electrode in case that you did not reach where you wanted to reach with the macro. Right.
Yeah.
But there's also ways to plan your trajectory so that you can reach where you want to reach and also protrude a little bit. You don't protrude the whole wire. That's what the whole troubleshooting was, is you need to plan ahead how much distance you want for that micro wire to go.
Yeah.
You can have like 10 millimeters, but you can also have 2, right? Or 1.
So you can have 1, you're still getting good yield?
2 to 3, we got really good yield. 3 millimeters was our average.
Anybody else? Okay, thank you very much. That's very, very good.